Very good. So how do you spell it?
HIPA.
You got it. Yeah, most people say they think it's HIPPA, and it's actually HIPA. You what?
That mistake.
You have made that mistake before? Yeah. So that's a big concern in this environment, is protection of patient health information. And you don't get that necessarily on a university campus because you're not dealing with health information. But in this environment, when we recruit patients into studies, I can't, even though I work here and I run the research program here, I can't wander down a hallway into a patient's room and say, "Hey, I know you have a stroke. I'd like you to join our study." So I can't know that patients are here. So we have to have intermediaries that do the initial recruitment for us. And so when we do studies here, we very commonly use recruitment brochures, and those are tools that the therapists use to take to the patients to see if they would agree to have someone come in and talk about the study. And if the patient agrees, all we need is a verbal consent. If the patient agrees, then I can wander in there and talk to the study or to the patient about the study to see if they want to go any further to be included into the study. So that's a big difference with what you get on a university campus and the types of studies that you might be involved in.
Yeah, in fact, everybody here has done some compliance training because of the research projects that they're involved in.
Yeah, excellent. Okay. So
and I have some brochures to give you.
Training, you did that, very good. So you know,
oh, she has the brochure. Yeah.
So she has a brochure?
She has brochures for this ongoing, the AC study.
Oh, all right.
AC Fitbit study. Fitbit.
Okay.
Fitbit and hopefully AC also. Oh, perfect.
There they are. Yeah, so that
Probably I have to give them to you.
yeah.
The only problem is these are fine, but this one is the edge of it is kind of reversed. So
What percentage of patients tend to be readmitted? Is there?
Yep, very small percentage of readmits. You know, that's a big deal in healthcare now because after October of last year, if a patient is readmitted to a hospital after a hospital stay, if they've been readmitted within 30 days, the hospital has to give money back for the original stay. And so tracking readmissions is a big deal. We've been doing it for patients that are discharged from St. Luke's for about 2 years now. And our readmission rate is way below 10%. So closer to 5 or 6%. And sometimes it happens. You know, patients are still pretty ill when they are discharged from St. Luke's. And so you're not going to have a 100% success rate. Sometimes patients do have to come back through the acute care system, and then they end up here. We don't hope that happens, but it's a rare occasion. That's a good question.
On the patients that you ask, what is the percentage of people interested in the actual study? I mean, there are not very many that are interested, or there's actually pretty good response. So.
No, we've had really good success with the projects that I've done with Diane and her students. Part of that is that I've been able to train up a pretty consistent set of therapists to work with me for the recruitment part of it. And so they know the studies are going on. They're constantly evaluating whether a patient would be appropriate for the study. And so these therapists really build a close relationship with the patients. That's the other thing I didn't mention is how long the length of stay at St. Luke's is. So average length of stay over in an acute care facility like Sacred Heart Hospital, just uphill, is maybe 2.5 to 3 days. The average length of stay here is 2 weeks. And so our therapists are seeing the patients every day, usually several times a day, and they need to get to know the patients very well. And so that really helps out with studies. So study where we're doing the ambulatory circuit.
Excuse me?
A really easy sell to the patients because it's really not something that interrupts their therapy, and it is a very short term. They have 2 testing periods a week apart where they have to wear the sensors. Other than that, we don't really bug them. Now I go in and check with them every day to make sure that they haven't had some type of adverse event. And we've had a couple in that study, which are reportable to the IRB. So everybody knows what the IRB is, right? So anytime you have a patient enrolled in the study, you don't have to do this with psychology students on university campuses. But when you are working with patients, you as the investigator have an obligation to track them to know whether they've had any type of adverse event while they're enrolled in the study. And that's whether the adverse event has to do with participation in the study or not. So, for example, we had a patient who participated in the ambulatory circuit study on, say, a Tuesday in the morning. And then Wednesday morning, I went in bright and early, about 8 in the morning, to check on the patient and found out that the patient had fallen. It was not related to participation in the study. She was in the bathroom and wanted some privacy and was not strong enough to be able to lift herself up off of the toilet seat very well, and ended up losing her balance and falling and hitting her head. And nonetheless, because she was a patient that was enrolled in the study, it was an adverse event that I had to report to the IRB. And so we've had a couple of instances of that. None of them related to the study, but still they're reportable. And so that's another difference when you're working with patients, is that you really have to track them. Even when they're not doing anything study related, I go in every single day and make sure that we haven't had any type of events that would be reported to the IRB.
Now, once they've done the second circuit, does that stop, or do you
No,
continue? Okay, I didn't know
No.
if you continue with them after.
No, that's the end of their participation in that particular study. So for this study, I don't know what to predict on this. This is going to be a little a different situation because we're going to try to enroll the patients very soon after they're here. It's in a period of time where they haven't developed a lot of rapport with anybody. And so this is probably going to be a little tougher to recruit for.
And they have to wear something continuously.
They have to wear something continuously, and so, it's going to be maybe a little easier for patients to say, I'm just not interested.
Yeah.
But I am absolutely amazed at how, at the goodwill that our patients exhibit to want to participate in studies. And this symbol right here, WSU Cougar, a lot of patients, once they see that and they know that this is a WSU study, they're in.
Yes. The loyalty is.
Yeah, so a lot of times that helps too. Just knowing that this is a study that is affiliated with them.
Yeah.
Kayla's here.
Yeah, hi Kayla. So Kayla, this is about a third of our current Gerontechnology class. And Kayla took the class, I'm gonna say 2 years ago, something like that, yeah. And recently published few papers from it.
2 papers from our project, yeah.
And now your research is centered here.
Yes.
And so I don't know, I'll let you two work out, because we asked Kayla to come talk about her project. So
Yeah, well, I think when we get down in the community, maybe that would be a great time for you to describe your study.
Absolutely.
So I thought what we'd do is just kind of move around the hospital a little bit. We'll work our way 2 floors down, which is where St. Luke's community is, and take a look at that facility. And so a good place to start, I think, is just by maybe, we're going to kind of cycle through this gym right here. So go in that door and we'll come out right out the door that's right out here on the other side. So you can see some of the equipment that would be used in this gym. This gym has dual purposes. It's both for our cardiac rehab patients, and I didn't really mention that as a very prevalent patient population that we have here. We We do see patients on an inpatient basis that have had some type of heart procedure. A good example would be if someone has congestive heart failure, their heart is failing, it's going to stop, the heart is actually dying. One of the things that can be done to try to prolong a person's life is to implant what's called an LVAD. Anybody know what LVAD stands for? Left ventricular assist device. So it's a little pump that's actually implanted in the person's chest that helps the heart to continue pumping. And so we've been seeing an increase in the number of patients that have had LVADs implanted coming to St. Luke's as inpatients. If a patient has a heart attack, the way that cardiac rehab has gone nowadays is that they're usually discharged right to home from the acute care hospital, and then they do cardiac rehab on an outpatient basis. And so this gym is used for our cardiac rehab program, pulmonary rehab, and it's also where we have our spinal cord injury patients come to do work with the therapist. And so you'll see kind of a combination of cardiovascular equipment and mat tables, great big tables that the therapist can get the patients on to work with them as we kind of cycle through there. So we'll go in this door and come out right across from our support system. And you also have these orthoses that are attached to the patient's legs. And the orthoses are motorized so that they will move a person's legs through a walking pattern while their treadmill is moving underneath their feet. And so for a patient that has no use of the legs or very limited ability to use the legs, this would be a type of therapy that we would have them engage in. And so a lot of things can be varied on this, everything from the biomechanics of the orthoses that are on the legs to the amount of body weight support that the person is supporting as they're walking on the treadmill, to variables like how fast the treadmill is moving. And so this is a pretty expensive piece of equipment. But one that you can imagine, if you've gone from being able to walk to all of a sudden not being able to walk, you want to regain that capability. Questions about this? Yes.
So how the patients, they like give the feedback about this equipment? Do they like it, or do they feel maybe the equipment cannot go very smoothly with their walking style?
Well, even when the patients are in this device, it would not look like a completely normal movement pattern, but it's the closest thing to walking that many of these patients are going to experience again. And so the effect that it has on the patients is that they love using this device because it simulates a walking pattern for them, which is something that they don't have the capability to do. So it has a very high satisfaction with the patients.
Is there any stem cell therapy stuff going on with something like this for people that have the spinal cord injury or anything like that?
Oh, there's a lot of stem cell therapy research that's going on in different places in the world.
Okay, but they're not doing any of that here.
No,
Okay.
no, we're not doing stem cell research here. So
Okay.
that's more in hospitals that have labs associated with them to be able to do more phase 1 clinical trial studies, and we're not set up to be able to do those.
Okay.
So which phase are you set up to do?
We can do phase 2 studies. The 2 studies that we have going on right now are both phase 3 studies. And then of course phase 4, if we're doing post-marketing, contributing to studies that might be post-marketing studies, we would be involved in those. You know, we don't have a vivarium, so we're not involved in animal studies.
No genetics or genomics here.
Right, yeah, we don't have any sequencers to be able to do genetic studies. Although a lot of times when we've got patients involved in studies, the consent form will allow them to choose whether they do or don't want to be involved in genetic sub-studies that might be part of a larger study. And that you can get that with everything from a skin sample to blood. So we do have patients that consent to be in genetic studies. A good example would be this shark-only tooth drug trial that we have going on. Because that is an inherited disease, patients are, they want help, and so they don't mind sharing their genetic material with researchers in hopes that they might be able to get closer to a cure for that type of progressive disease. But you get into other studies, stroke studies would be a good example. And the patients get a little more nervous about sharing their genetic material. Understandable. Other questions?
Quick question. So, I mean, this machine, right, it doesn't actually involve like hooking up to like, some
Electrical?
exoskeletons, how just some signals in
Well, these orthoses would be exoskeletons.
Okay.
They are trained to work with the device, and the software helps to run the orthoses. I thought you might have been asking about what's called functional electrical stimulation, FES.
I guess that's what I mean.
Yeah, so we do have an FES bike over here, and that would be a device that if a patient had limited use of the lower extremities, we can put electrodes on the quadriceps and the hamstring muscles, and we can provide electrical stimulus to the muscles to get them contracting so that they can do things like ride a bike. And so that's called an FES bike, functional electrical stimulation.
I have a question, maybe something related, fundamental biomedical question. If a person gets injured, what is the mechanism that this physical practice help them rehabilitate? Is that to help them muscle develop or neuron regeneration?
Yeah, so it depends on if it's an injury to the nervous system. I think that's what you're asking about, is if you have an injury somewhere in the nervous system, either at the level of the spinal cord or even in the brain. So we'll use the example of stroke. There are two broad categories of strokes. There are ischemic strokes that occur because of a blood vessel supplying blood to the brain gets blocked, and that could be a blood vessel that was anywhere from the neck up. And in situations like that, if you have a blockage of a blood vessel supplying the brain, let's say that it's a smaller artery that's up in the brain, if that vessel becomes blocked and there's not collateral circulation to supply the nerve cells that depend on that, then you have death of those nerve cells, and it will create an area in the brain that's called a lesion, in which you basically have dead nervous system tissue, and the human body's pretty amazing. It goes in and begins trying to clean out that dead tissue almost immediately. And so if you have a lesion that has knocked out neurons that are part of a constellation of neurons that perform a certain function, then one of the targets of therapy is to try to generate plasticity of the nervous system to be able to regenerate some of the nervous tissue that now is missing. And so the mechanisms for that are varied. It usually doesn't mean that the lesion is filled in by fresh functional nervous system tissue. It means that there are collateral connections that are made with other neurons to help try to regenerate the circuit. But the nervous system after injury has a period of time that's, depending upon whose research you believe in, is up to several months long, in which it has a high degree of plasticity. And it's a period of time where you want to try to maximize the amount of therapy work that a person is doing. And so that's a pretty big change over the way that therapy was viewed maybe 20 years ago. 20 years ago, the goal was to try to teach people how to compensate for lost movement capabilities. And nowadays, the whole goal is using this notion of neuroplasticity, is to try to help people regain use of lost functional movement patterns.
In fact, the first time my mother-in-law was here, she had a horrible bike accident and remember her spinal nerve damage?
Yeah.
And ever since then kind of drags one side and has limited use of that side. And you mentioned a study where they will actually like limit the use of the other side, so you're forced to just use the affected area for a couple of weeks.
Yeah. So that's a relatively common therapy technique used now. It's called constraint-induced movement therapy. And so to try to keep people from doing what's natural, which is to use the non-involved limb, what they do is they tether that limb, they put a mitt on it, and sometimes will tie it to the person's body so that they can't use the functional limb, and then they go through hours a day of practice with using the involved limb to be able to perform some functional tasks, some tasks that you never would perform again in your life, but still it's providing input to the nervous system to try to take advantage of this, the plasticity. The good thing about the nervous system is that it stays plastic across a lifetime. The basis of neuroplasticity is really the basis for forming memories. And it doesn't matter how old you are, you can still create new memories. And so this process of neuroplasticity is something that remains with us from birth to death. And so therapy tries to take advantage of a period of time where you can capitalize on an extreme period of plasticity in the nervous system. Other questions? Well, let's head down to the bottom floor. So we were down on the first. We're on the second floor right now. We'll go in the stairwell down to the first floor and just keep on going. We'll go all the way down to the basement.
Conditions. So we're recruiting people who have different neurologic conditions such as multiple sclerosis, traumatic brain injuries, history of stroke, Parkinson's disease, and some other disorders as well. Pretty much the gamut, as long as they have some sort of cognitive deficits that result from a neurologic condition. And what we want to do is look at performance in a novel community shopping task. And so the task that we do, it's performed down here in the community, and it's basically a simulated grocery shopping task. And so we have people start over in the office area, and we give them a little recipe book and some other materials, and I read them the instructions that basically they're going to have some friends over for dinner, and they're going to be making Hungarian goulash, so they need to look up the recipe for Hungarian goulash, decide what items that they need to purchase in the store, because we also give them a list of items that they already have at home, so they kind of need to make those decisions. And then we also ask them to buy stamps from the cashier when they check out, as well as purchase a chocolate dessert from the store. And then we tell them after they're finished shopping, they have to board the bus for their trip home, and they also have to watch for the safety light before crossing in front of the bus. And so, like I said, they start over there and they go through the task. We have a hierarchical queuing system that we do in order to guide people through the tasks if they run into any problems completing any step of the task. So this pretty much entails me telling, kind of walking through the task if they get stuck. And the first level of queue is just kind of an indirect thing. So for example, if they were making their grocery store list and they left off an item that they do need to get at the store, I might say, is there anything else you need to put on your list? So it's really open and not direct. If they're still confused as to what I'm talking about, I go to the next level of queue, which is gestural guidance. And so I would point to maybe like the item that they forgot, something like that. The next level is direct verbal guidance. So I would say, you forgot to put the 3 onions on your list. And so then they would hopefully write that in. But if they're still having problems, there's other cues too. So then there's physically assisting them, so like maybe putting their hand on like an item that they haven't collected from the grocery store area, or just doing it for them. And so, like I said, when they're over here, they're making their grocery list, and once they're ready to go, we give them cash and a bus pass for them to use for their shopping trip. And they go ahead and go grocery shopping. Once again, during this whole time, I'm queuing them if needed, if they're not collecting the certain items that they need. And then we also have a little interruptions task that we do. So after they've collected 3 different items in the grocery store, I interrupt them and tell them that their neighbor just called and that her 3-year-old daughter Eva has a fever and she needs her to pick up some children's ibuprofen from the store so that she doesn't have to take Eva out of the house. And so that's just a way to kind of add that disruption and some other kind of component in there that they have to problem solve through and remember to grab that's not already on their list. So hopefully then they'll grab the children's ibuprofen. I act as the cashier, so then they come and they check out and they do have to pay me the correct amount of cash, and they also have to remember to ask me for stamps at this point. And then once they're done grocery shopping, they're supposed to walk over to the outside area of the community, cross the crosswalk using the light. If they cross before the light says walk, then that would be another queuing system that I would go into. And then once they get in front of the bus and hand me the bus pass, then they're finished. So part of the importance of this particular task is really to evaluate more of functional everyday tasks. For those of you who know anything about neuropsychology, the job of a neuropsychologist is to try to understand what kind of deficits people are experiencing in their everyday lives, right? And so we usually do this by giving them a lot of different traditional neuropsychological tests. And these are usually paper pencil tasks or like little memory tasks. So for example, in order to test their memory, we might read them a list of 10 words and ask them to repeat back those words. In order to test their processing speed, we might have them fill in these numbers according to this code at the top of a paper, and then they do that. In order to test working memory, we'll give them some digits, some numbers, and they just have to repeat those numbers directly back to us. So those are the kinds of tests that we traditionally give to try to assess for different cognitive domains and areas of weaknesses and for strengths. However, a lot of times during those testing sessions, people don't really see the point of those tests. They're like, I'm not reciting these random words in my day-to-day life. I'm not filling out these coded sheets in my day-to-day life. So what's really the point of all this testing? It doesn't really make sense to them. And there's been a lot of question as to how much these tests relate to how the person's doing on an everyday basis. So part of the community shopping trip task that we've developed is to help make up for that area of weakness in a lot of our testing and help really understand, how does an everyday task relate to our more traditional cognitive measures. So on top of the person going through the shopping trip task, I also give them a 2-hour testing battery of different cognitive tests. And so I'm going to be comparing, how they're doing, on the community shopping task in relation to the more traditional cognitive measures, as well as their self-report everyday functioning abilities, and seeing the predictive value of those. So that's the main project. Any questions about that?
I'm curious what you found. Have you found that it aligns with the traditional tests or not?
Well, I'm still collecting data, so I don't completely have that answer.
Okay.
I was also going to mention, this project has kind of evolved. It used to be that we were testing inpatient participants, and I do have a number of inpatient participants that we've collected data on, and that original goal was to really evaluate the efficacy of using the community in rehab compared to traditional measures too. So that's not also something I've looked at, but we've continued to collect a few inpatient participants here and there. But with our outpatient participants, the project that I was just talking about, we haven't looked at the data, but obviously the hypothesis will be that the community shopping task is going to be related to more of the everyday functional tasks, but I have yet to discover that.
She just had her proposal.
Yes.
Oh, okay.
Presentation less than a month ago.
Yep.
That was good, thank you.
Yeah.
Yeah, so that That's another way that we're using the community in another WSU project. Should I real briefly go over the ambulatory circuit
Yeah, I think so.
project?
They saw a video of it,
Okay,
so they
all
have a
right.
high level.
Yeah, it's you know, it's a pretty straightforward project to look at what types of information can be obtained from the shimmer sensors, and if that information can be converted into feedback that would be useful for the clinicians and also for the patients. And so that's kind of where we're going with that particular information. We also have been looking at whether information that we can obtain from the sensors that look at different metrics of walking, of gait, whether those have any relationship with a standardized functional assessment that we do in inpatient rehab. So there's a standardized assessment called the Functional Independence Measure, the FIM, as we call it, that patients are administered when they are admitted to St. Luke's, and it provides a baseline for what their functional abilities are on lots of different activities of daily living. And then they're actually refimmed daily, although some of the disciplines are able to get to the patients every day and others are not, so we don't really depend a lot on what's going on with the day-to-day films. But the other one that counts, that is really that we have to do for reimbursement purposes, is the discharge film. And so the difference between the admission and the discharge film is a metric that we use to see how much improvement a patient has made during their stay in activities of daily living, basically. So the idea is that when a patient is discharged from St. Luke's, we should have an idea of their level of independence, which then translates into how much they're going to have to depend on another person to be able to perform activities of daily living on a day-to-day basis. And so our goal here is that a patient is not dependent on anyone else to perform ADLs at discharge. It doesn't always work that way, but we at least hope that if the person has a caretaker that's going to be with them, that caretaker is involved only for maybe an hour or two a day in assisting with necessary activities of daily living. So the ambulatory circuit starts right there. You're going to be our patient. And you know anybody that's had a stroke? Okay. What I want you to do is to shuffle with your left foot. I want you to use what's called a hip hiking gait. What does that sound like you have to do when you walk? If you hike a hip.
Put your left side of your hip.
You got it. Yeah, you're kind of pulling the leg through from the hip to be able to get it to move forward. So you're gonna simulate a patient with stroke, okay? So from there, so he's already sensored up in the project. So we've got sensors on both ankles, and then we've got one that is on the lower back. And then from there, he's given a countdown: 5, 4, 3, 2, 1, begin. And if the patient is using an ambulatory device like a walker or a cane, they use it during the testing. We make sure that we standardize the footwear, so whatever they wear on the first testing occasion is the same footwear that they wear 7 days later. And so from there, then you'd be given the countdown, and then you'd stand up out of the chair. Now, I don't want you to pretend that you've had a stroke right now. I want you just to stand up out of the chair.
Oh, and we do have a sensor on the walker or the cane.
Yeah.
As well,
So that was pretty easy. Go ahead and sit back down. So if you had balance deficits and maybe compromised strength because of the stroke, and your ability to be able to walk, the walking pattern was compromised, you'd take a lot more time to get up out of the chair. And so the therapists work with patients on what safe techniques are for being able to even get up out of the chair. And so now I want you to pretend there's a walker out in front of you. And so you're going to stand up. First you want to put your hands on there you go. Get yourself going. Then you're gonna get out and reach for the walker. Then you got one leg that you're gonna be hip hiking to get it carried through. You're gonna walk forward, coming this way. We don't give them any cueing about the types of surfaces they're going to be walking on. For example, we don't point out.
That's a lot of work, isn't
Be really careful because you're on shag carpeting right here. We don't give them any cueing about you're better off with you know, something that has wheels on it like a walker with walking on this smooth surface than you are coming over here to the carpet. So the patients just pretty much select where they move in the task. And so you're coming forward. Then you're doing a great job. Then at this old ragged piece of masking tape on the ground that's now become part of the ground, I think, is where we ask them a question. We ask them we ask them, when was your birth date, not how old you are, when was your birth date? And the reason we do that is similar to what Kayla's doing in her study. We want to try to throw in an unexpected event to find out what happens to their gait when they're asked to do something that is cognitively challenging. And so, when was your birth date?
February 30th.
February 30th of what year?
1983.
February 3rd?
Yeah.
Okay.
February 13th.
13th, okay, all right. See, it's effortful to remember when your birthday is, especially if it's unexpected and somebody just asks you that.
I have a little thing that I track them with too, and I write timings down as they're going from point to point. And the birth date is also so that I can verify that what's on the medical chart for age is accurate as well. So.
Yeah, we try to hope that they actually give us an accurate birth date. We've not had many issues with that. So the idea, there's a relatively simple test that's called stops walking when talking. That is very predictive of falling. And so if a person has to stop to engage in a cognitive task, then as they're walking, then that is an indicator that they're at elevated risk for falls. And so that's the reason that we ask that. You know, we've tested 35 patients so far. I think we've only had one that has stopped. So most of them just continue ambulating as we ask what their birth date is. So come on through. What's your birth date?
June 3rd.
June 3rd of?
94.
Okay.
I have to mark whether they stop or not. So.
Young stroke. So then they make a circular pathway around the white SUV. We don't tell them anything about watch out and figure out what you're going to do to get over the manhole cover.
It's very much in character.
I have to, if they have a problem with the manhole cover, I have to actually indicate it.
I was afraid he was gonna fall.
Yeah.
Yeah, he could. So the door is already open for them to be able to transition into the vehicle, and so before they come down here and do the testing, they've already been given training by the therapist on how to do a transfer in and out. Doesn't mean that they always remember, but if you've got a walker in front of you, it makes sense that you're going to have to do something with that to be able to get into the seat of the car. And so most patients kind of will stop and think about what they're going to do at this point, and then they'll kind of do what Aaron did over there. Yeah, kind of get moved around, and then they back up so that they can get close to the seat. And then they kind of find it, they search with their bum to figure out where the seat is. And then they're able to transfer in. Once they're fully in with both feet on the floor, then I say, and back out. And then they come back out of the car. Yeah. They get back to the walker, and then we go just complete the circuit back to the chair and sit down again. So your stroke's over with. Okay, we'll come back in here now. So that's even though any of us would have very little difficulty being able to perform that task, with patients, it is sometimes a very effortful process. They are having to relearn different capabilities like walking, and certainly balance is often compromised with a stroke. We throw in a few cognitive things that they have to remember, like how do you transfer in and out of a vehicle when you've never used a walker before in your life. And so safety is a big thing that we work on with the patients. And all the time we're collecting all of this, lots of data from the sensors. And so once they get back to the chair, then we do a few calibration things, and then the trial is over with for that day. Take the sensors off. The patients come back exactly 7 days later, and we do the testing again, and so it provides us with the capability to look at changes in some of these gait metrics after 7 days of therapy. And patients do engage in therapy even on weekends here. So it is a true 7-day period of time where the patients have been engaging in therapy.
But we do the first walk 2 times that first day, and then we do it when they come back 7 days later 2 times again.
Yeah, 2 trials on each day.
So one thing I'd like to throw out is, I know Tao is part of the step count project where they're trying all kinds of devices to determine
Fitbit?
accuracy.
Okay.
Fitbit, Apple Watch, I don't know, you've got a lot of
Fantastic.
them. Is anybody else here on that project? Or is it just you, Tao? In fact, we were going to talk to you about seeing if we could borrow a couple devices.
Yeah.
But you can imagine how difficult it is if you have a walker to assess their gait with wearable sensors. And then, I wasn't there, but I can only imagine you kind of shuffle to get into a seat, into a car. And so what does that mean in terms of counts? And so steps.
That's actually a great thing to think about the different transitions that a patient's going to be making. Same thing with getting out of the bed.
Yeah, right.
So what happens to the counts that are being made as a patient goes from lying to sitting to standing. And so when you're doing these, you really need to be thinking about what are the capabilities of a young person in being able to make transfers into and out of different devices, everything from a bed to a toilet seat to a tub to a seat in a car, and back into those things, and see what happens to the counts as you're engaged in these different ADLs. Unknown. I haven't seen anything published that's looking at that.
No, other than this group, a couple of them did it for a class project last semester, so they have a boosted starting point. And their findings were that they're wildly inaccurate.
Yeah.
But,
Yeah,
under
you
what
shared that.
conditions and so forth, that remains to be investigated.
Yeah. Maybe the best that you can hope for is that even if there's general inaccuracy in the number of counts, at least it is systematic error.
Yes.
that the number of counts that it makes when a person is engaged in one of these transition activities remains the same or relatively the same.
Yes.
And so I think that's probably the best case scenario is systematic error instead of something that is just random wobble. Okay. Other questions? Your arm is probably getting very tired.
I might need the round after this.
So do you ever have patients that are unable
Right
to
place.
complete the
I'm at the right
circuit
place
on the
to
first
do
try,
this.
or would need
No, the therapists that I have working on recruitment, they have been really careful to make sure that the patients that come into the ambulatory circuit project have the capability to do the distance. And that's kind of one of our screening criteria, is that I check with them almost on a daily basis to say, is patient so-and-so able to do the entire distance? Well, no, she was only able to walk 10 meters today. Okay, well, we'll come back in a couple of days and see if she's able to walk the full distance. So we've not had any patients that have not been able to complete both trials on each day of the ambulatory circuit, but part of that is because we're being very careful with screening.
So one kind of closing question I have for you, especially since we're trying to train all these young people to go out and design what is going to be used for the next generation, is what's at the top of your wish list for technology assisting?
Yeah, you know, and you're beginning to see development of these types of products. It doesn't mean there's still not room for more. Something that was a very low cost but accurate system to be able to allow patients to engage in therapy using the hands and the arms after discharge. So it's this idea that patients work really hard when they're here at St. Luke's. We have no idea what their level of activity is after discharge, other than what patients tell us, which is, I'm just not as active as I was at St. Luke's. And so to be able to design equipment that would keep them engaged after the discharge is something that would be really valuable in the therapy world. The other thing is trying to figure out ways to monitor activity. You know, these things are going to be amazing. I think that this project that we're doing is actually, well, it's the first one that I've seen that looks at level of activity in patients who are hospitalized in an inpatient rehab setting. There was that one study I think I shared with you that looked at physical activity with sensors in an acute care setting. But we've got him here for 2 weeks. And so we're going to be able to collect data over a much larger time horizon to look at level of activity, and then being able to have patients wear sensors after discharge to find out what their level of activity is, I think is going to be a really valuable thing. You know, these things are not only devices to record level of activity, they're also valuable at providing feedback about level of activity. And so that's the other thing that we don't know is, you know, you see the commercials on TV for Fitbit where you've got all of these sleek, athletic-looking people wearing their Fitbits that are out there, and the Fitbits are driving their level of physical activity. Well, not everybody is sleek and athletic that wears these things. I'm a good example of that. So we don't know how these devices work to try to motivate people who are not slick and athletic. And so trying to use these devices to stimulate activity in patients, I think, is another important area.
Would that be something we could consider as a follow-on to this, is
Absolutely.
letting them take one home?
Yes, that's where we're going with this.
All right.
So we want patients to begin wearing these.
Yeah.
You know, keeping it, so when you're developing lines of research, you need to think about really what's going to be the most successful study to do at the very beginning, and then build on that. And so that's why putting these on patients at St. Luke's, I think, is a really good idea. We take them back before discharge.
Yeah.
Very controlled environment. I can stop in and check with them day by day. You know, once they get after discharge, we have issues with being able to make sure that they're adherent with wearing the devices.
Yeah.
Issues with, will they remember? Sometimes I forget to charge mine until all of a sudden I've got the little signal that says the battery's almost gone, and then hopefully I remember to plug it in. So.
Well, then you look at the like the Garmin that I have. I've had it for 1.5 years, and I have yet to have to plug it in and out, have to take it off to shower or do anything. So then you have to look at how does that compare to, say, the one you're wearing, and you know, this would be better for a patient because now, as long as we can sync it eventually, they don't have to think about it. They just wear it.
Yeah.
So,
We might be able to get somebody to donate a whole pile of them, and so, you know, there's no strings attached. You go, you keep it, and then optionally share your data.
Sure. Yeah. Would you like to continue wearing it afterwards?
Yeah.
We're still going to be collecting the data, but you can walk out the door with your sensor.
All right. Well, we'll talk about that.
so I would think the manufacturer would want to know how it's working as well.
Yeah.
Because then they can say, hey, this is our study with older adults and how well it works for them, not just people that are doing fitness.
Yeah, that's the other thing too, is that the patients that are here, we do have pediatric patients at St. Luke's, but most of our patients are over the age of 50. And so in a Gerontechnology class, you're in the right place because it's making you think about this great big bubble of baby boomers that are coming through and going to be a very prevalent segment of the age group in the United States. You need to be thinking about the types of services and products that they need. It's not going to be the sleek athletes that are in the Fitbit commercials right now. You know, will people my age adopt these as devices that help motivate movement, and especially after someone's had a serious injury to the nervous system or orthopedic injury?
Yeah. Yeah, it's gonna be huge. Any other questions? Well, Doug and Kayla, we cannot thank you enough for your time. I mean, it's one thing to hear us talk about it, but to be here
Yeah.
and see is so helpful. So,
Well, I like doing this.
Thank you.
I love working with students. Diane's students are really top notch. I've had, when I was in academia, I had hundreds of graduate students, and Diane's students are right at the top in terms of the pecking order for students that I've worked with. So it's a real
oh, thank
pleasure to
you.
work with.
They
with
are
your
good.
students. Yeah. Okay, so my email address is really easy. It's weeksdl, and Diane can hook you up with my email address, weeksdl at St. Luke's. That's the hardest part. It's st-lukes without an apostrophe.org. And so feel free to email me if you have ideas or questions, and we can engage in some conversation about that.
Excellent. Very good. Thank you.
Yeah.
And a lot of these guys will have a poster session at the end of the academic year. And so, you know, we can kind of update you even at the end of this semester so you can see what they're working on.
Great.
We'll email you their
You know,
posters.
that's a publication waiting to happen. This idea of looking at accuracy of the different wearable devices
Yeah.
when people are engaged
Yeah.
in different activities, using different things for ambulation.
Yeah. Just a big survey across all the devices and the different conditions. Yeah.
Mhm. Yeah.
Yeah, I agree.
Okay. All right.
All
Thank you
right.
for
Thank you
for
so
making the trip
much.
up here, everybody. Hope it was
This is
useful.
fantastic.
Thanks.
Thank you.